Okay, so I'm going to present our long-term results with a special kind of prosthesis, which is a stemless metaphyseal reverse shoulder arthroplasty. I want to acknowledge all my fellows over the years that for the hard work that they collected very meticulously the data. Two of them are here, George and Andreas. And they know that if they don't collect the data, they will be slapped on their wrists. This is my disclosure, and I'm the designer of this prosthesis. So we know that reverse shoulder replacement, and we heard it already, is gaining popularity in recent years, and actually it's exploding in popularity, and you can see that in the US, since 2003, when the first reverse been approved by the FDA, it's been exponentially increased, and there's loads of them. Now a lot of different systems, most of them they're stemmed, and we know that in the USA, in the UK, in Germany, in Italy, now it's about 60 or more than 60% of the total shoulder replacement are reverse. I don't know what's in Norway or in Greece, and in France, I know John is up to 80% or even more. So it's actually going stronger and stronger. Now, it's not without complications, and we heard very nicely from Bruno about the complications and what we need to do to avoid them. And we can, you know, I don't have to go through all these complications. We all know them. We all know that it's quite high. And maybe now they're less than it was initially because we learn more, we are better, but still quite a high rate of complications, including notching and all that. More worrying than that is the significant reoperation rate. And we all know that to remove a well-fixed stem like that is a nightmare. Now we know from the paper by Pascal Boileau in 2005, he saw 22% of reoperation in primary cuff arthropathy. And his groups, Matthias Zumstein, when we worked with him, published up to 60% reoperation in rheumatoid arthritis and revision a reverse shoulder replacement. And you can see here in the bottom in blue, this is a graph from Brad Edwards that he presented in the closed American Shoulder and Elbow meeting in 2014. Just in 10 years, how many of revisions of reverse shoulder arthroplasty happening? And this is very worrying because what we see in recent years, we see these disasters. We see revisions with longer and longer stems and less bone stock. And I ask you guys, what next? What to do next? To chop the arm off, to chop the head off? What to do next? Or these, again, two more examples. What next? And this is just the tip of the iceberg because now we see more and more done by more and more surgeons, some of them less experienced. So this is really just the tip of the iceberg. So in order to avoid that, what we need to do is we need to develop a different point of view, a different angle of view. We need to look at the patient journey or the patient shoulder journey through his life and preserve all the steps for the next steps, what to do next and how to follow him for the rest of his life when he comes young to us or youngish to us with a problem. So with that in mind, we designed in the late 90s, in 1997, actually started with the idea of the stemless reverse shoulder replacement with a verso, which is a tripled fin stemless metaphyseal prosthesis. We have now more than 12 years of clinical experience. The design principle is a minimal bone resection and actually bone-preserving prosthesis. It's a stemless metaphyseal prosthesis, and it's fixed to the cancellous bone only, and there's no diaphyseal stem. And we use a cementless fixation with bone impaction technique. In that case, we can use it in most of the cases. As you can see, this is the bone impaction technique, and doing that, we can actually, by impacting the bone into the humerus, because a lot of these patients are osteoporotic patients, the rheumatoid patients, a very soft bone. So we don't have problem with that because we can impact it and we can continue to impact. We use the punch, we can put some more bone, and then we put the real implant inside. And you can see that after we impact it in, of course, we don't test it with a inserted on because the lever arm is very, very long. But if you test it now, you can see it is rock solid. And it's amazing. If you haven't tried it, when you try it, you are amazed how solid it is. And about the glenoid side again, we heard about the glenoid, the fixation, the problem, and then we found a different solution. Again, similar idea of penetrating the cortex, the medial cortex, but with this tapered shape screw that you can see in a study done in Imperial College in London, comparing 6 different prostheses. You can see the yellow is the Verso, and the Verso came the best with the maximum micromotion of 48 microns. And the majority, you can see it's only on the edges. The rest is blue, which is less than 10 micromotion. Again, if you do a prosthesis that you know, all people have to use, it is to be simple, because if you make it too complex, you make too many steps, there will be mistakes, because you can make more mistakes. So keep it simple, and this is simple. There's only 2 trays to do the implant. We have this tapered shape liner, which is we can dial it. It's dialable. We can dial it exactly to the direction of the best direction of the patient. So if we are not happy with some rotations, we can really dial and adjust for each patient in the last minute. And just look over here, what happens with just doing that. We really clear the space. And as you know, the notching is not because of adduction, it's because of rotational movement of the plastic on the glenoid. And imagine that by doing that, not only that we reduce the notching, but we improve the rotational movement, as you can see here. So we looked at our patients with 5 to 12 years follow-up done between 2005 and 2011. Just to pay your attention to the rotational movement of this lady, look at her rotation. I mean, we talked about earlier about that the rotations are not so good with reverse, but that's not what we can see with this prosthesis. Now, we had 172 consecutive patients, and 149 of them were stemless. The rest, 23, were stemmed implants, because they were for other reasons that we needed to have a stem, either revisions of a stemmed implant or fractures or non-unions. You can see that 50 of all these prostheses were done as a revision arthroplasty, 21 from a stemmed implant to a stemmed verso, and 29 to a stemless, when 3 of them from a stemmed to a stemless. One of them I showed in a previous talk. You can see that we assess the patient in constant score, subjective shoulder value, satisfaction, and x-rays, and we take video clips of every patient in every visit, so people will believe to what we're saying. So this is, again, you can see this lady, she's 6 years after bilateral versos. Look at her rotations. I mean, I'm not sure that I can do this. And we did a study that we published in the JSCS about bilateral reverse shoulders. There was a concern whether if you do bilateral and they can't really have rotations, they can't either reach behind the back or they can't reach to the mouth. You can see all the constant scores that has improved here substantially, again, overall to about 59 and 86.8 as age and sex adjusted. Again, I'm talking about the rotations. The rotations improved substantially. Again, both elevation, but external rotation that was improved to 51 degrees and internal rotation to 67 degrees, as you can see here. The results have been held over the years. On the long term, they did not deteriorate. We didn't see any deterioration with time. And you can see here that we have a constant database. We all the time put it in a computer, and you can see that the results remained as they were over the years. You see that it takes them about 6 months to a year to get to the plateau, more or less the plateau of improvement. Different cases or different indications. This is a rheumatoid arthritis. We have quite a big group of rheumatoids, about 42 patients, shoulders with in 32 patients. A lot of them are revisions from other prostheses. And you can see this gentleman has got his before right shoulder, and on the left one he's got a surface replacement. He was quite happy with the surface replacement. It wasn't great, but he was okay, not painful. And after we did the first verso on him, the right one, he came and asked to be revised to the, on the other as well. And you can see here is the 5.5 years after the right and 2 years after revision of the left. And you can see the results, overall, very good results. We haven't seen any major problem with this group. We had some complications, as you have to, and we had 2 undisplaced fractures of the humeral metaphysis, which we actually fixed with a PDS cord around and just treated conservatively, and it healed without any problems, without any subsidence, and without any loosening afterwards. A glenoid fracture, again, during the preparation, we managed to fix the glenoid because we have a lot of screw holes. We can use the screws as osteosynthesis, and we fixed it again, treated them more conservatively, and they healed. We had no infections in this group, and no other intraoperative complications. There were 3 dislocations. One patient pushed himself out of a chair 1 week after surgery and dislocated his shoulder, and we had to revise him, and one of them had a small osteophyte that every time he did this, it hinged the shoulder out, so we had to revise both of them. This is the guy that you can see here with a hinged, and this is his result actually 5 years down the line. Again, we just had to take the osteophyte out and adjust, dial the liner to the right position, and that's it. We had fractures of the acromion, and this lady actually had a fracture of the acromion, and then we didn't know what fractures of the acromion are. It was just before Gilles wrote his paper about this, and we wanted to operate on her. And the good thing about the NHS in England is the waiting time, because she had to wait, and when she came back, she said, "Prof, I'm fine, I can." So actually, we don't have to do that. Fractures of the spine of the scapula, we had 6. 3 of them were operated, 3 were not operated, and I must say that the ones that were operated were worse than the ones that were operated. But they were moderate recovery. Again, they're not painful, but function is not great. We had 4 traumatic glenoid peripatetic fracture. Again, 1 was conservative, 1 refused surgery, and 1 was revised, or both were revised, but 1 was revised. And this is the lady that you can see at the bottom. And this is 3 years after revision. Again, the nice thing about it, because you have a central screw where the fixation is so good, as long as you have a tiny amount of bone, you can really revise it and fix it to the medial cortex as well, and there's no problem. Radiographically, we have no lucencies around the implants. We had no notching in 132 shoulders. In 23% of the shoulders, we had notching grade 1 and 2. Actually, in 19.8% grade 1 and 2. And only in 6 cases, we had grade 3 notching, 3.5%. And this was when we used a retentive liner, which I do not recommend to use anymore. This is a major problem that we see all with stemmed implant, whether it's reverse or anatomic. We see the stress shielding and the disappearance of the proximal humerus. Gilles Valch and his group wrote about it, and Luc Favard as well. And you can see what you do when you have to revise this. This is a major problem. I mean, you have no bone left there. And some prostheses, you see it more than others, but you see it in all. And I was surprised to see that in recent papers that even the short stem prosthesis, the Ascend Flex, has showed in less than 2 years severe proximal stress shielding. And I believe it's because it's a short stem and it fixed to the shaft rather than the metaphysis. But we haven't seen any stress shielding or subsidence or loosening or lysis of the tuberosities, and I think because we have a direct load to the cancellous bone there. Young patients. This lady, she's 45 in this small video. She's 23 years after having total resurfacing. She was the youngest patient that Steve Copeland did at the age of 22 for juvenile rheumatoid arthritis. Now, she lost a cuff, and I revised her to a verso, and this is her 6 years after the revision. She's 51 years old. She's got excellent function. You see no problem around the bone. Again, I don't know if this will last for the rest of her life, But if he doesn't, I still have all the bone stock there and I can do something else. This one is my youngest patient. He had a fracture at the age of 17. Actually, I should have done a hemi-arthroplasty, but he was 17, so I fixed him. And he developed AVN. I had to do a resurfacing afterwards. This lasted about 12 years, and then he lost his cuff, and this is his function. He's a painter and decorator. He can't do the ceilings. He had to employ someone to do it. We had a long and hard chat about it, and again, he's 33. He was 33 when we did the operation. And he wanted to do it, so we did it. He's now over 2.5 years. This was last year. He's doing very well. He's back to work. He's fine. I don't know if this will last forever, for the rest of his life, but he's got all the bone stock there. If worse come to worse, we can always do a hemi, or we can put something else, because the bone is there. And the patients are returning to sports and different sports without problems. And this is my craziest patient. Then when first I heard that he's doing this skydiving with his suit, I didn't want to hear. But then I said, if you are doing, he said, listen, I'm going to do it, whether you allow me or not. I said, oh, okay, if you are doing it, give me a picture. And then he told me that I improved his technique, because when he had the hemi-arthroplasty, again, this is a stem to stemless. When he had hemi-arthroplasty, he couldn't move his arm more than that. And they have to do this when they jump from the plane. So he was jumping like this, and he said he would go down in spirals. Now he can fly properly. So I'm not recommending it, by any way. So this is a very difficult group of patients, and this is a work that George Arealis did when he was my fellow. This is the weight-bearing shoulders. We presented it in SECEC and in the American Academy. This is a difficult group of patients. A lot of surgeons do not want to touch them because they are weight-bearing around the shoulder. And what we found, actually, that the results are the same as the other population. The only thing is that you have to be prepared. You have to prepare them, the family or the carers, because for the first 6 weeks, you have to take care of them with a hoist to move them, because they shouldn't put any weight in the first 6 weeks. But otherwise, they show the same good results as the other group. Now, our good results with stemless implants are supported by the other stemless implant that have been out there similar time, is the TESS. And they show good results with stemless reverse, but I must say and Bruno is sitting here and he can confirm that even the designers of the prosthesis, of these prostheses, are using it, or using the stem, the small stem, in more than 80% of the cases, because they found the bone too soft to use it without a stem. So only less than 20% they use without a stem. So it's possible to use it, but it shows good results. But here the selection is important. Again, I think it's to do with the shape. Just to show you an extreme case, this gentleman is 89. He's got an eggshell. He's got a cyst. You see, he's got nothing. Okay. I put a bone graft substitute, as you can see, and this is him a year down the line. All the bone is incorporated. He's got no subsidence, no loosening, nothing. And we have all the bone. You may argue that this is in this age I could put a stem in, but I just want to make the point. Again, let me ask you, periprosthetic fractures. Again, we live on planet Earth. We don't live on the moon, so there's gravity. These elderly patients, they tend to fall. If they fall, they fracture periprosthetically. Would you like to treat this one or this one? Well, I know it's a rhetoric question. I prefer to treat the metaphyseal one, because this will heal in conservative treatment. And you can see this lady, her function after conservative treatment, and this fracture is healed. Again, it's not as perfect as it was before, but it's functional and she's painless. So in our series, we had eight patients with periprosthetic fractures. 6 of them we could treat conservatively with good results, and only 2 that were displaced we had to revise to a stemmed implant. But stemless is not the answer for everything. There are cases where you can't use stemless. You need, for instance, in acute fractures or non-unions or severe bone loss that you don't have any proximal bone, Or, again, I put a question mark here, if someone else been there before with a long stem, you may have to use a stem if you can't preserve the proximal humerus. But for that, you have a stemmed implant, and this is what we use now for fractures. Again, I think for elderly patients, this is now the way forward. So to conclude, the stemless reverse shoulder replacement gives an excellent long-term, up to 12 years, clinical and radiologic results. It's bone preserving. It gives outstanding rotational movement, or actually a range of movement, including active external rotation and active internal rotation, long survivorship, no loosening of subsidence, and better revisability. Again, I invite you all to come to Israel later this year. Thank you very much.